Okay, well, good morning and welcome to our April GIC meeting. I'm Valerie Sullivan. I'm chair. I'm delighted that we're meeting in April here on a beautiful spring day in the Boston area. I am joined by our esteemed board here and the staff of the GIC, as well as some guest speakers. And I want to say hello to everybody who's joined us on the live stream or you're watching remote after the fact. But I'm going to turn it over to Andrew now to take roll call and looking forward to a great meeting.
Thank you, Madam Chair. We are joined today by Chair Sullivan, Vice Chair Kaplan, our designee from Administration and Finance, Dana Sullivan, our designee from Department of Insurance, Rebecca Butler, Commissioners Chabot, Commissioner Choate, Commissioner Davis, Commissioner Edmonds, Commissioner Jennings, Commissioner Murphy-Rodriguez, Commissioner Silva, Commissioner Sinenko, Commissioner Sullivan, and Commissioner West.
Okay, great. Well, thanks. We got a full house here. So let me turn this over to Matt, and Matt, you can take us through today's agenda and then we'll move along.
Great. Thank you, Madam Chair. Thank you, members of the commission and staff and those joining remotely. Welcome to our April meeting. We appreciate the flexibility of the commission to meet in April. We weren't sure we would need it, but we do need it for a few items that we wanted to update you on and have a vote. So we will begin today after our executive director's report with an update on the GIC's health equity strategy. That presentation will have two parts. We have a guest speaker joining us, Michael Bailett from Bailett Consulting, who's been playing a key role in organizing a variety of state agencies and other actors in developing aligned quality measures and data sets that, as we have spoken about in past meetings, are really essential to our long-term health equity strategy. Margaret Anschutz on the staff will also present some GIC-specific updates on health equity, so we're excited to bring that to you. We will also have the vote, the one substantive vote of the meeting. We're bringing a staff recommendation to the commission for the procurement of our data analytics vendor. So those are the two main items today. It may look like a short agenda, but these are two important and meaty topics for us.
Yeah, no, I think it's great. They're terrific topics and happy to see the follow-up on health equity and looking forward to some progress and some metrics. So at this point, let's just go back to last meeting. I will take a motion to approve the minutes.
So moved.
Second.
Okay, so I didn't hear who made the first and second motion. I think it was Bobby and Toby.
Yes.
Yes.
The second, Toby.
So at this point, I will ask Andrew to take roll call on vote, but I'm aye. So go ahead, Andrew.
Thank you, Chair Sullivan. Vice Chair Kaplan,
Aye.
Designee Sullivan,
Aye.
Designee Butler,
Aye.
Commissioner Chabot,
Aye.
Commissioner Choate,
Yes.
Commissioner Davis,
Abstain, I was not present.
Commissioner Edmonds,
Aye.
Commissioner Jennings,
Aye.
Commissioner Murphy-Rodriguez,
Yes.
Commissioner Silva,
Yes.
Commissioner Sinenko,
Aye.
Commissioner Sullivan,
Yes.
and Commissioner West.
Also abstain since I was not here.
I don't believe, let me just The motion passes unanimously from those voting.
All right, thanks, Andrew. So let's get into the meat of today's meeting. So if we want to keep moving forward, Matt, do you want to take it away with Executive Director report?
Yep.
Thanks.
Happy to. Thank you, Madam Chair. So we don't have a written Executive Director's report this month, but I do want to update you on some important elements of our healthcare claim spending and budgeting. As you all have heard throughout the year in our CFO reports, the GIC has been averaging a fairly significant monthly deficit of about $20 million throughout the year, due in large part to rising provider prices and the utilization of prescription drugs, particularly the trends around our GLP-1 drugs for weight loss. Our most recent spending in February and March did not materially change our deficiency, which we still project to be $240 million for the current fiscal year. In our February meeting, we also suggested that the governor was likely to file a supplemental budget, which he did in April. And this includes $240 million in additional funding for the GIC. That spending bill is now before the House Committee on Ways and Means. We are working closely with our colleagues at Administration and Finance to ensure that the legislature understands the urgency of moving this legislation. What we want to do is avoid disruption to our members, our health plans, and to the providers that rely on our prompt payment of claims. And we are likewise in the process of meeting with our health plans to make sure that we're prepared to manage any disruption that may come along our way if there's delayed action. So at this point, I would say this should not be the cause of alarm, as in my judgment, it's unlikely that the supplemental budget will not be enacted in a timely manner. But it is certainly a cause on my part for concern and focus, since by our current projections, our current appropriation is sufficient to pay claims only through the 12th of May, 2025. So we're keeping a very close eye on that and working with all our colleagues to make sure that we can move that over the finish line. In related news, the House Committee on Ways and Means just late yesterday released its version of the proposed budget for the coming fiscal year. We are in the process of reviewing that. Our hope is that with the FY26 budget now out of House Ways and Means, they will quickly turn their attention to the supplemental budget that includes our funding to get through the end of this fiscal year. So the House Ways and Means FY26 budget, this is the beginning of the legislature's process, and they will take it up in the full House the week after next. With that, I'm happy to take questions that commissioners may have.
I don't see any questions. Why don't I see the chat? Oh, here we go. Oh, Dana, I see you have your hand up. Hi, Dana.
Hi, I just want to echo what was just said about the supplemental budget. ANF is tracking it very closely and hopeful that it will move quickly, given the House just released their budget, and also just to flag that the Senate budget will be released in a couple of weeks. So we are very much in FY26 budget season.
Oh, great. Thank you. We appreciate that. I don't see any other questions. I have I'm sure other commissioners are thinking the same thing. Hiring and backfilling for our CFO, how is that going?
Yeah, that's going quite well. I'm working closely with Emily Williams, our Chief of Staff, who's sitting in for Jim, managing the budget team with our acting CFO, Catherine Moore. So the position's been open now for several weeks. We have a good list of candidates, and will likely be moving to interviews shortly. We understand the time sensitivity of this, given all these important dynamics, but we are on top of it and with the absence of a formal CFO, but we'll be moving expeditiously on that.
Okay, well, definitely keep us posted. Thank you, Emily, for jumping in and taking on additional responsibility. Thanks to Catherine for her help. Definitely want to recognize them.
Yeah, Catherine and Margaret Byrne too. And
Margaret,
the rest of the team is really stepping up to fill the void in the short term.
excellent. That is great. Bobby, your hand was up.
Yes,
yeah.
I'm just curious regarding the funding is, because we're sort of over budget now. Do you think that the GIC will have to amend its FY26 budget request? Do you think what is?
We don't, because while we have been consistently running a deficiency, it's been pretty consistent. So we were able to build an FY26 budget that reflects those trends. So I don't anticipate that FY26, if it proceeds based on the governor's request in House 1, that we would need to adjust that.
Okay, thanks.
So I don't see. And then one last just update that I'm sure the commissioners are also thinking. How is open enrollment going? Are we seeing many concerns by our constituents, questions, and overwhelm in the call center with Paul's team? Anything that we should be tracking on behalf of the staff?
So as we typically do, we will have in June a full report out, but I'm happy to say that annual enrollment is going smoothly. Our members have been quite engaged this year, not surprisingly, given the increases in our premiums. We have consistently strongly urged our members to shop for their options, and the early indications are that they are indeed doing that. Use of the My GIC link member portal continues to increase, as Paul will report in June. The call volume into our operations team is pretty steady. So all things are going quite well to this point in annual enrollment.
Okay, great. Thanks. All right. Well, thanks, Matt, for the update. We can keep moving.
Excellent. At this point, we'll move on to our health equity update. Oh, sorry. Quickly touch on the calendar. So in our May meeting, we're looking forward to bringing you a refreshed out-of-pocket report. We have heard the Commission's feedback in years past on how we have designed and approached this reporting. And this year, the data analytics team has been hard at work reworking this year's report a bit. In addition to providing data on member out-of-pocket spending trends and comparisons from past years, we're broadening the scope a bit this year to include some more high-level financial and enrollment trends. We hope that these changes will give the Commission greater context for the FY24 out-of-pocket trends and in new and different ways. This is a kind of a process that will likely continue to tweak over the year to come for next year. So we're eager to get some feedback from the Commission on that report in May. Also in May, we will begin the process of reprocuring a life and long-term disability vendor. That first step in the process will be a vote to approve a consultant to assist us with that process. So that's what we have lined up for May. In June, as I mentioned, we will come back with an update on annual enrollment after that has concluded. And as always, we'll look for opportunities to weave in other items as appropriate. So that's the calendar as it looks through the remainder of the fiscal. Happy to take questions.
We can keep moving. Same calendar every month. We stay consistent. I like it. All right. Well, really excited to have this presentation. So Margaret.
Yeah, I think I'm on.
Thanks, and take it away.
All right. Good morning, commissioners. I get the honor of introducing our next speaker, Michael Baylett. Michael is the president of Baylett Health, a well-known consulting group that works with public agencies and employer purchasers, supporting efforts to drive insurer and provider performance accountability. He and his staff publish extensively in journals such as Health Affairs and Millbank, sharing widely best practices and lessons learned to the healthcare community. Baylett Health supports clients across the country and has contributed to the development of many policies in the same areas as GIC's strategic priorities: affordability, behavioral health, and health equity. We invited Michael to speak to you today in his capacity as the facilitator of the Quality Measurement Alignment Task Force, or QMAT, an industry and statewide initiative of the Massachusetts Executive Office of Health and Human Services. QMAT's charge is to define an aligned measure set for use by payers and providers in commercial and Medicaid global budget-based risk contracts. The GIC sits on QMAT and uses its clinical measures and data standards for reporting and for performance guarantees with our carriers. I know commissioners have valued market-level presentations from our sister agencies such as CHIA and the Health Policy Commission. Hearing from Michael will give you the chance to hear about the statewide process and the industry-wide conversations around defining the clinical measures and data standards that we use at the GIC as part of our performance guarantees and our health equity work. On a more personal note, having worked closely with a few members of Michael's team, both here and when I was at CHIA, I want to add that he and his colleagues are also deeply passionate about improving equity across the health system. It's really palpable. During Michael's presentation, I ask that you hold questions to the end. And following the Q&A, I will provide a deeper dive into GIC-specific initiatives around health equity. Michael, thank you again for joining us today. I hand the presentation over to you.
Yeah, thank you, Margaret. Welcome, Michael. And I just want to reiterate what Margaret asked. If we could hold all our questions throughout Michael's presentation, we did build in time in the agenda for questions and comments. And there'll be plenty of time, so thanks. So yeah, Michael, welcome and take it away.
Thank you. Good morning, commissioners. I'm happy to be here with you this morning. So I'm going to tell you the story of the Quality Measure Alignment Task Force, its past, its current activities, and its future. So the origins of the task force go back to 2017 when EOHHS, in partnership with CHIA and the HPC, convened the body for the purpose of creating an aligned set of quality measures for payers and providers to use in their contracts. The focus for the aligned measure set was on the commercial market and Medicaid, and not Medicare, because there's no opportunity to influence the quality measures that Medicare uses. The initial objectives were twofold. One was to reduce administrative burden, primarily on provider organizations that were confronted with different purchasers, asking them to focus on different measures, and generating measure sets that were so large that it was literally impossible for the provider organizations to respond to all of them. The second objective was to create some greater focus and prioritization of provider quality improvement work so that the likelihood of measurable improvement in performance would be enhanced. The task force's, next slide, please, three goals are to build consensus on an aligned measure set for voluntary adoption by private and public payers. Two, to identify where there are gaps in measures. And three, to advise EOHHS on measurement and reporting of health and healthcare equities and creating accountability for reducing inequities. The composition of the task force, next slide, please, is heterogeneous. There will be 25 plus members participating in a given meeting. You can see here that it's a diverse array of representatives participating in the meetings. There is a lot of clinical expertise, a lot of performance measurement expertise, and a lot of debate. These are highly interactive meetings. People bring different perspectives, and in my role as the facilitator of the body, we try to find a way to get to, if not full consensus, then a strong majority adopting a given recommendation to EOHHS and to the secretary, who ultimately blesses the aligned measure set each year. And I would say that because of the diversity and the expertise, the level of discourse is quite high, and the decisions that are made are thoughtful and highly informed. Now, the task force's product, I said, is an aligned measure set, but there are really two subsets, and I want to explain this beginning on the next slide. There is first a core set of measures. So these are measures that payers and providers that agree to voluntarily adopt the aligned measure set are expected to use in all of their contracts. So these are 6 very high priority measures, and they cover a few different domains. I'm not sharing with you today, but there are a set of criteria that the task force has adopted for its overall measure set and specifically for the core set. So I'll highlight here these 6 just because they are highest priority. The first measure is actually a consumer experience survey, the CG CAP survey, and they use the Mass Health Quality Partners version of it. So payers have some flexibility in contracting with providers to pick one or more measures from that survey. There is one pediatric focus measure, child immunization status. There are 2 very important interim outcome measures, controlling high blood pressure and blood sugar control, measures 3 and 4. Those 2 measures have a significant impact on morbidity and mortality. And then there are 2 behavioral health focus measures, screening for clinical depression follow-up plan and substance use assessment in primary care. The task force annually reviews these core measures and the menu measures that I'm going to present shortly on the next slide, and makes little modifications each year. So measures will move on and off of the set. There's not wholesale change in a given year, but there are changes made annually as part of an annual review process. In addition to the core set, there is a menu set. So the menu represents measures that payers and providers may choose to use in addition to the core measures. They need not use them, but they are asked to restrict the measures that they do put in their contracts to these menu measures. So the totality of the universe for contractual measures are the 6 core measures, and however many of these menu measures that the purchaser and provider want to use. And these bold-faced measures are ones that the GIC is using right now. Some of these measures are in high use among payers and providers, and others of them less so. I'll note measures 17, 18, and 11 are measures specifically focused on health equity, which has been a priority for the task force. And I can talk about these measures later, should you have interest in. So as I noted earlier, this is a measure set for voluntary adoption, and annually CHIA surveys the payers in the state to ask them which measures they're using in their contracts. And it's really impressive that despite this being voluntary, the payers in the state have robustly supported adoption of the aligned measure set. And so we measure our fidelity rate. You can see back in 2020, on an all-payer basis, we were at 72%. We're at 94% in 2025. And that's really impressive because most payer-provider contracts are multi-year, and the fact that we take measures on and off in a given year means it's really hard to get to 100%. But despite that, we have 4 payers that are 94% and above, which is about as high as we could ever get. The only payer that's been problematic for us is United Healthcare, which is at 53%. And I think this is a result of the fact that it's a national insurer that tends not to adapt its measures to an individual state. Conversely, we are fortunate in Massachusetts that our insurance market is dominated by domestic health plans, and they are much more likely to align with the Massachusetts specific set. So this is great performance. I will note, because we do similar work in Rhode Island and in Connecticut, that in Connecticut, which is another voluntary state, their fidelity rate is far below what we have here in Massachusetts. Okay, let's go to the next slide. So I want to talk a little bit about health equity and the task force's work. So in 2022, the task force created 3 different technical advisory groups, and I want to explain what each of them has done. The first one was a technical advisory group to recommend to the task force new measures that might be added to the aligned measure set that would focus on measurement and improvement in health equity. And that group did make recommendations that resulted in some of the measures that are in the aligned measure set. There was also a technical advisory group that recommended how to introduce accountability for reducing inequities in provider contracts. And so this was a group of payers and providers, and ultimately they agreed on a framework that was published, and you can access that through the hyperlink if you want to after the meeting, for how to modify contracts appropriately to introduce accountability for health equity. And then last, but in some ways first, there was a health equity data standards technical advisory group. And this group in 2022 recommended data standards for the collection of race, ethnicity, language, disability status, sexual orientation, gender identity, and sex data. And those standards were developed for adoption, again, voluntarily by payers in Massachusetts and by large provider organizations. Just recently, UHHS procured a new data standards technical advisory group, which had its first meeting earlier this week. It is reviewing the standards that were adopted in 2022 and advising on whether they need to be updated. That group is going to meet over the next handful of months and then make recommendations to the task force and to the secretary on modifications to the current data standards tag. That process will probably repeat every 3 years, simply because the national landscape for demographic data collection is evolving, although I would say right now at the federal level it's devolving. But overall, it has been evolving, and so there will no doubt need to be continued refinements to the standards. But I said that this was last, but in many ways first, and the reason I said that is because you can't do meaningful measurement, you can't do meaningful stratification of quality measures unless you have complete, consistent, patient-reported data of these demographic data standards. And until you do, the measures that you might stratify by any of these variables will be suspect for its validity. So a high priority for the task force has been advancing consistent collection of data using these standards. The last thing I'll note is even though these standards were developed in 2022, they were recommended for phased implementation because some of these demographic variables we found from a survey we did a few years ago, were not being collected at all in Massachusetts. And the one I will most highlight is disability status. There was literally no collection of disability status by payers or by providers, with the exception of Mass Health, that as a proxy had some data because some people are eligible for Medicaid due to disability status. But aside from that, there was nothing occurring. So I would say, if I were to assess where are we as a state in terms of collecting these data, we're doing better in race, ethnicity, and language, and we're not doing as well with the other variables. But hopefully, through continued promotion of the health equity data standards, we will make continuing progress. Next slide, please. So there are a couple of measures that are in the aligned measure set right now that focus on health equity. I'll note one of them is a measure titled REL stratification. REL is race, ethnicity, and language. And it calls for payers and calls for provider organizations stratifying all 6 core measures and 6 menu measures chosen at the discretion of the payer and provider, and stratifying by race, ethnicity, and language. The task force recently recommended that for 2026, disability status be added. And it will probably add SOGI, sexual orientation and gender identity, in future years. The task force has twice asked ACOs to voluntarily share stratified performance data with CHIA for 4 of the aligned measure set measures, most recently for 2022. And what we have found, not surprisingly, is that there is a disparity in performance across race, ethnicity, and language for these 4 measures. The performance has not been publicly reported yet because there's not yet confidence on the validity of the data that all of the provider organizations are collecting. And until the data are both more complete and have been validated, the task force members felt that it would be inappropriate to publicly report the data. That being said, there are some individual payer and provider organizations that do self-report their data. Blue Cross Blue Shield annually publishes a health equity report with their information stratified, I think, just by race. And there are some provider organizations, UMass Memorial, Mass General, that also self-report their stratified data. Next slide, please. So the task force is in transition. On January 7th, the governor signed Chapter 343 into law, and it mandates the use of a state-adopted standard quality measure set. So essentially, the voluntary aligned measure set that was created upon the creation of the task force in 2017 will become mandatory. This won't have a great impact on most insurers because you could see we had a pretty high level of voluntary adoption. But for some national insurers like United Healthcare, it will have an impact on their business practice. The law requires CHIA to convene a new body called the Statewide Quality Advisory Committee as soon as possible. That will probably happen sometime this year. And so this Statewide Quality Advisory Committee will replace the task force. The state will procure a technical advisory group to support the advisory committee. And individuals and organizations can sit on both groups. The current task force is going to serve as that technical advisory group through the end of their current term, which is November. And it's quite possible, and I will say, I hope it will be the case, that many of the members of the task force will apply to participate on the technical advisory group, given the valuable knowledge and experience they bring. So these are changes that are coming. The next slide has a little bit more detailed timeline on the change. What's coming up. So this May, the task force will complete its annual review of the aligned measure set. for 2026. So for 2026, the measure set will continue to be voluntary. Next year in May, the new advisory committee, with support from its technical advisory group to be, will recommend a measure set for mandatory use beginning in 2027. And this is just for global budget-based risk contracts, which is how the aligned measure set works today. In the future, the aligned measure set per the statute is to expand to other contract types. So for example, value-based payment arrangements with hospitals aren't currently part of the aligned measure set, but might be in the future. And in addition, the new advisory committee is supposed to identify measures for use in tiered network health plan design. There's no timeline for when this will happen. For now, the only publicly set timeline is to move the current global budget-based risk contract aligned measure set from voluntary to mandatory beginning in 2027. That is my presentation. I am happy to take questions.
Well, thank you very much. That was very interesting. Let's see. I don't see any questions yet, but I was taking copious notes. So I wonder if you could go back to page 15, please. So you talked about the reporting, like what's the, not to get into the weeds, but what is the mechanism for reporting? So how do they submit the data sets?
Sure. So what we have done is we have asked the accountable care organizations in the state if they would voluntarily share their stratified performance data with CHIA. And so they directly transmit it for just these 4 measures using whatever data standards they were using at the time for race, ethnicity, and language to CHIA. CHIA then aggregates the data across the ACOs for these 4 measures, stratifying commercial and mass health. So we had separate measures for each. And then during meetings of the task force, they presented the data and we talked about it as a group. Because we didn't have full adoption of the health equity data standards, not all of the ACOs were using the exact same categories. We anticipated that would be the case. If we can move longitudinally towards greater adoption of the health equity data standards, then we'll be sure that provider organizations and payers are collecting data exactly the same way, and that will facilitate aggregation and meaningful analysis of where inequities exist and where we might want to prioritize improvement efforts.
And so thank you. In terms of ACOs, how do they differ from, physician groups, hospitals that aren't part of an ACO? So I guess the question is, are we capturing all the data or is it a small subset?
I would say that every large medical group and health system in the state right now is operating as an ACO for at least some of its contracts. And when I say some of its contracts, I mean for the commercial market, for mass health, and or for the Medicare market. I don't think there are any large entities, at least of which I'm aware, that are not engaging in this type of contract.
All right, great. Hey, Jane, I see your hand is up. Why don't you go ahead?
Well, thank you. Thank you, Madam Chair. Well, first of all, I just have to say to you, Michael, that I can understand why you're held in such high esteem for your comprehensive work and your knowledge. So thank you for the presentation. I'm just curious from your perspective, since you have sort of a view of the larger landscape. You work with many different states, as I understand it. Can you tell us a little bit about how you think Massachusetts stacks up? I kind of always have thought that we lead in terms of, our health equity, recognizing that there are disparities along the lines of race and ethnicity and sexual orientation and disability, as you say. But I'm just curious, from your perspective, are there certain kinds of best practices that are going on in other places that are getting at the root causes of the health disparities that affect people of color and the disabled community and other groups? Is there something more you can tell us that would help to sharpen our thinking about these issues?
Yeah, thanks for your question. I have to acknowledge I don't know everything that's happening in every state, despite the fact that I work in a lot of states. I will say that when it comes to developing health equity data standards, Massachusetts is at the front of the line. When it comes to doing—
Are you saying now that we're at the front of the line or have
Yeah.
been?
Yeah. We're best practice there. In
Okay.
terms of measurement and reporting of health equity or inequity, there are some other state Medicaid programs that are a little bit ahead of Massachusetts, but we're certainly in the leader group of states. But the real question that you ask, and frankly, the most important question is, well, what about activities to actually reduce the inequities? And that's the hardest work. I mean, you do have to start with measurement because otherwise you don't know where inequities exist. But the really hard work is to get at the origins of those inequities, and that's super hard work. And to be honest, I don't know if there's any state that's demonstrated really impressive proficiency in being able to do that.
Yeah, well, I appreciate your candor on that because, from my perspective, when I think about root causes, I can't help but ignore what I believe are structural racism and, historical inequities that have existed and have contributed to the disparities that exist today. So my question is always, so what is being done about that to try to, in a climate that seems to not want to even acknowledge that historical.
For sure at the federal level. And I will say there, even before the change in presidential administrations, there are many states that wouldn't even talk about equity.
Right.
But Massachusetts and some others long have and continue to do so. But you are right that that structural racism extends way beyond the healthcare system. And so if you want to reduce inequities, yes, you need to pay attention to what happens in the healthcare system, but there are all sorts of social determinants that exist outside of the healthcare system. And there's been lots of debate over the last several years. Well, how far does the healthcare system's responsibility extend beyond healthcare to get at the roots of inequities? We, in our work with the task force, whenever we present a measure, we share with them available data on that stratifies performance on that measure by the demographic variables for which we have data. And sometimes we're using Massachusetts data and sometimes national. And we're stratifying not just by race and ethnicity, but for example, we frequently will stratify disability status. The inequities when you stratify by disability status are absolutely galling and often far greater than they are by race and ethnicity. So the opportunities to improve health equity are great, and they exist in many areas.
Well, thank you. I'm just grateful for this presentation that we live in a state that would bring this conversation before the public because it's an important one. And I'm glad and I'm very, very pleased with this presentation. Thank you so much for.
Yeah, I'll conclude by saying, to be honest, we got a long way to go. I mean, I'm
That I
glad we're
know.
doing
That
some
I know.
measurement, but
Trust me. That I know. That's what I constantly say all the time. Even the phrase that we have more work to do is kind of a tough expression for me because I right away want to say, so tell me about what the more work is going to look like. Will you measure it so we know we're doing it and hold ourselves accountable? But thank you anyway for the presentation. It's great.
And on that last point, I'd just add, if we can go back to slide 14 for a moment, the accountability element of this is really critical. I mean, we will not be surprised. We are not today. We will not be surprised tomorrow to learn that there are widespread disparities across a number of different areas. There was a presentation at the Primary Care Task Force, which launched yesterday, that highlighted specific areas of access concerns that have a health disparity component to them. So we will not be surprised to find these wherever we look in healthcare, but that will confirm them. But it will give us a mechanism to hold actors accountable for progress. Like, to me, that is like absolutely critical. We can, if we need to lean into this work, we are, and we will continue to. But if we can't measure progress and show that we're actually being successful, then we're missing an important component to that too. It does also occur to me, Michael, maybe you can comment on this, that perhaps one of the reasons that Massachusetts is at the forefront in this data gathering and standards development for health equity, that we had a pretty firm foundation with the history of the QMAT work that goes back many years. So I remember, Michael, attending meetings that you facilitated when I was at Harvard Pilgrim, and that's 7 years ago. So we created this foundation of a standard measure set to be used across all payers. And as that work has proceeded, we've been able to fold in elements of health equity. So without that prior work, I would imagine it would have been more difficult for us to be at the state that we're in today.
Yeah, I think having the task force provided a platform for doing other work, including this health equity work, that would not have existed otherwise. I'd also say an asset that Massachusetts has that other states do not have to the same extent is it's a relatively small state, and people know how to work with one another, and they even know one another. There's some large states I work with. I mean, I remember doing work in Pennsylvania where the people in leadership positions didn't even seem to know one another, and the culture was not collaborative. I think people know how to work together in Massachusetts, and that's a facilitator.
Very nice, very nice.
I think Toby's got his actual hand up. Yeah.
I couldn't find the feature for
That's
put
all
the
right.
hand up. Just a curiosity question is, do you have a target date when you think you're going to have gathered enough data from enough providers in a similar format that you're going to be releasing some of the metrics, the results?
You mean the stratified data?
Yeah.
No, and I will acknowledge this is a bit of frustration for me. We had a plan that this year we were going to run an analysis to try to validate some of the data so we could begin to report it. And we ran into some roadblocks. And so we recently had a setback there, which is unfortunate.
Is it data collection roadblocks?
No, it was a validation.
Okay.
We're going to do. And we ran into some data sensitivity issues. So we got to find another way to get it done. But I think there is commitment to continuing to trudge forward.
Yeah. Thanks, Toby. I don't see anybody else's hands up. I promise this is my last question, Michael. In terms of the data, when it is available, is the committee or task force thinking about contractual obligations or, in our RFPs where, if you want to be part of the GIC or bid on our business, these measures are, ultimately required, and we can put like financial penalties by not, complying. I mean, is that way too ahead of the thinking of your task force?
So, I mean, I don't know that by and large that you'll need to do so. Um, let me explain. So to the extent that you are contracting with health insurers that are now going to be required by law to use the aligned measure set, those measures should already be in place. So you should have alignment. The only place where that might not happen is if you are contracting with an entity that is not subject to the law. So I'm thinking, for example, I think you contract with WellPoint. And WellPoint, I'm not sure because I don't remember the statutory language, but they or may not be subject to the requirement to use the aligned measure set. Actually, they would not be because they are not engaging in global budget-based risk contracts. So that might be a case where you would need to use your purchasing authority to make sure that they are aligning. But you should be okay with the other insurers that are already going to be subject to the law.
Okay, I hope you're listening, WellPoint. Hey, Anna, why don't you go ahead and take the floor?
Yeah, I was just gonna respond to your comment actually that you just made asking about sort of, I think you were actually making a good point, which is not only do we want these sort of a standard set of measures to be used, like mandating their use, but like there's another step, right? Which is what do we do in terms of payment, or how are they incorporated into payment contracts? And I think that there's still a lot of variability left for how that might be used, if at all, right? And so it is something I think that the GIC might want to think about and just like pay attention to how the payers are using these measures in their contracts. And I do know that the Blue Cross Blue Shield of Massachusetts was not, one of our carriers, but they do have pay for equity contracts. So they're not only measuring these measures, but they're also linking payment to reducing gaps. And so there are models out there to be looking at and paying attention to. And we might want to think not about only about like what are the data standards and how we're measuring them, but thinking about contracting as well.
Yeah, and I would say on that front, and that may be a very good segue to moving to Margaret's element of the presentation. We did have, as part of our last health plan procurement, embedded in that, and therefore embedded in our contracts, performance guarantees for our carriers that relate to a number of elements that we're talking about here. So the carriers today do have money at stake for making progress on a number of these dimensions and requirements of collecting data, using data. I think to your point, Anna, like having that flow through to their contracts with providers, I think is a key element to this. And Margaret can speak to those in a lot more informed way than I can. And I think so the exciting part here, as we've talked about in previous discussions on our health equity agenda, is that while this work is proceeding around data standards, data collection, accountability measures, we are moving forward in areas where we know that there are very well demonstrated acute areas of health disparities. So we're complementing this data work with a variety of other strategies. Happy to take other questions for Michael, but seems like a good segue to hand it over to Margaret. Go ahead, Toby.
Just say in a future meeting, could you kind of relay some of those areas you said you have been identified of with health inequity and basically tell us what we're doing about it? In other words, can you
we're actually going to do that next
okay,
today.
That's speaking you should receive. Thank you.
Yep.
It'll be a great segment. Yeah, Margaret, you're being accountable to showing progress that we are making here at the GIC towards, I don't want to say improving health equity, but maybe highlighting it so that we can make a difference. So let's turn this over to you. So thanks.
Thank you. Thank you, Chair Sullivan. All right, so I am here to provide this update and overview on our current health equity initiatives, and also provide a bit of a teaser on where we're going and what we're building to in the future. All right, you are familiar with this slide. Our strategic pillars at the GIC are affordability, behavioral health, and health equity. We view all of our initiatives through the lens of how they will affect these three pillars. Of course, they're all intertwined. You are familiar with our guiding principles listed here too. Of particular salience is the last bullet, align with other Massachusetts state agencies. Though often not mandatory at the statutory level, we believe that the most effective way to amplify state policy priorities is to work arm in arm with other state agencies. The QMAT and their related work is a prime example of this alignment. Next slide. All right, drilling down at these top three green boxes, we've got clinical performance guarantees, our health equity PG, and maternal health strategy. These are the topics I will be updating you on today. Speaking to clinical PGs, these are the clinical quality measures that the health plans report to us annually. You heard Michael talk about the measure set we draw from, and you saw on his slide a few slides ago, the blue bolded measures are the ones that we use in our contracts with the carriers as performance, as part of our performance guarantees around clinical efficacy and health equity. We expect scores on these measures to hit an agreed upon benchmark, and we tie financial penalties to success. On health equity, this PG is attainment or maintenance of NCQA health equity accreditation. I presented on accreditation standards in a prior commission meeting. We'll talk a little bit more about those today. And finally, on those active initiatives, we have a maternal health strategy that we're developing. As I previously discussed with you all, we know that birthing outcomes are worse for Black birthing people, regardless of income or education status. Later in this presentation, I will provide an overview of the program we are launching to target the disparities here and improve outcomes in this maternal health crisis. So for those blue monitoring boxes at the bottom, we're monitoring development around environmental performance guarantees. As you're likely aware, the effects of climate change and industrial pollution disproportionately impact the BIPOC community. Hospitals are increasingly looking at their environmental impact and incorporating sustainability measures into their practices. We are surveying the carriers about their thoughts in this area while we continue to follow industry efforts to reduce healthcare's climate impact. We do not yet have environmental PGs, but we are moving towards incorporating them into our contracts with carriers. Finally, on this slide, I'd like to provide a little more context on the recently passed Massachusetts PACT Act. As a result of this legislation, GIC is eliminating copays for the most utilized brand drug prescribed to treat diabetes, asthma, high cholesterol, and coronary artery disease. These are also conditions that are seen disproportionately in the BIPOC community, and that's no coincidence that those conditions were identified as the ones to target. By waiving copays associated with these drugs, we hope that access and adherence will be improved, and we hope to see that with this improvement, disparities are reduced. Next slide. This slide ties in Michael Baylett's presentation to the GIC on health equity work. You heard him talk about the work of the Quality Measurement Alignment Task Force, from building stakeholder consensus to defining data standards and clinical measures to include in payer contracts. To support efforts to push the market towards greater efficiency, accountability, and to tackle health disparities, GIC has included a subset of QMAT measures as performance guarantees with our carriers. Carriers are expected to return results in the 90th percentile nationally, as measured by the National Committee for Quality Assurance. Additionally, we hold carriers accountable for reporting on measures stratified by race and ethnicity. You heard Michael discuss the QMAT's process of defining data standards for collecting race ethnicity data. We have adopted QMAT standards and have asked our carriers to adopt these standards as well. We are still in the process of collecting this data as our carriers and providers. Michael also mentioned that the gold standard for race ethnicity data is member self-reported data. which industry stakeholders like state agencies, providers, and health plans are working on collecting. While self-reported data is being collected, carriers are also imputing race ethnicity data to supplement what is self-reported. However, while imputed data helps fill in the picture around health disparities and can guide population health initiatives targeting these disparities, much of the imputed data will inevitably be wrong at the person level, which is why we are pushing for vendors to constantly improve upon the percentage of their race ethnicity data that is member reported. It's also important to note that as we expect our carriers to stratify clinical measures by race ethnicity, we also do not yet have benchmarks to compare the results to, but are building these benchmarks by expecting a higher percentage of member-reported race ethnicity data collected by carriers year over year, and comparing the results of clinical measurements stratified by race ethnicity year over year. Of course, with those clinical results, as Michael discussed, there are questions around completeness and validity of the data that can be tied to the imputed data that stakeholders have. So we're really in the process of both collecting the data, pushing market participants to improve the percentage of data that they have that is self-reported, and really only until we get to close to 100% is it reasonable to release that data and start talking about linking the data and holding carriers and providers much more heavily accountable for the results. I want to remind you that we are doing this in concert with ACOs in Massachusetts, and this alignment enables greater efficiency across carriers and providers. So the QMAT standards and the measures are specific to ACOs. We are not in the ACO space, but by virtue of us adopting these measures and standards, we are pushing the market to more accountability, measurement, and all with the goal of increasing equity. Defining and implementing these statewide data set standards and measures also enable stakeholders like us and other policymakers to analyze data on an apples-to-apples basis, which is just crucial in policymaking. Next slide. A little more now on how we work internally with the PGs with race ethnicity data and measure stratification. We are currently reviewing carrier PG data with particular attention to race, ethnicity, and language stratification to provide feedback and contract updates to carriers. As you are aware, we also meet with the carriers twice a year for stewardship meetings. In our upcoming mid-year meetings, we will receive updates on carriers' progress towards collecting member-reported race ethnicity data and current population health programs that target health disparities. All right, moving now from clinical PGs to our health equity PG. As a reminder, in addition to clinical PGs and reporting on health disparities revealed within these PGs, we also have a requirement that our carriers attain or maintain health equity accreditation from NCQA. I'm very pleased to report that as of December 0.32, Health New England and Onpoint have all received accreditation. MGB Health Plan continues to make gains each year towards this goal, and we expect them to receive their accreditation very soon. The slide we're looking at now, you may recognize this slide as I used it in a previous presentation presenting a deep dive into what health equity accreditation entails for the carriers. I pulled the slide back into the discussion as a reminder of how comprehensive health equity accreditation is, and as a reminder of why getting and maintaining accreditation is an ongoing project. You can see in the second and the last box that accreditation involves collecting data and acting to eliminate health disparities. It also involves clinician training and cultural responsiveness, organizational training, and communication improvement. In short, these accreditation requirements push toward a cultural change within a health plan such that efforts to reduce health disparities are integrated and, most critically, operationalized. Next slide. So most of my presentation has emphasized data and clinical measures and how we're working with carriers and providers to use data to push for improvement in healthcare quality. This last slide focuses on one specific topic, maternal health improvement efforts and the GIC. As I've stated before, we're not going to wait to have complete data before working to reduce health disparities in our population. You've heard me talk about maternal health before, and cite research showing that Black birthing people have worse outcomes across both income and education level. We are developing our own framework and approach to addressing this crisis, with our pillars being supporting birthing people, promote quality and safety, foster provider accountability. In alignment with these pillars, we are in conversations with the Department of Public Health, Mass Health, and the Health Policy Commission about their efforts in this space and how we can support and amplify Massachusetts-wide efforts to improve health outcomes in the maternal health space. At the bottom of this slide, you will see the types of interventions we are evaluating, what's listed as hot topics in maternal health. I will be back to you in the next fiscal year with recommendations in this area, but I want to give you a sense of what we're currently working through. So first, there's doulas. We know that doulas improve birthing outcomes. These provider types are not yet licensed in Massachusetts, which is necessary to have in place before doulas can be brought in-network and reimbursed by carriers. The Department of Public Health is developing a state licensing process, and we expect coverage and reimbursement in the commercial market to follow. There are also options now to provide virtual access to doulas, which has also been shown to improve birthing outcomes, even as these doulas are remote. We will be evaluating this service for fit in the next year as well. BH support in this area. Again, there are virtual vendors that can provide behavioral health services, which is critical to everyone. And there are remote vendors in this space with training and expertise tailored specifically to pregnant and postpartum people.
Margaret,
then, yes.
Before you move off of doulas, can you just give a very brief description of what doulas do that might be different from others that deliver?
Thank you for the question. So doulas really provide a lot of support of what empowering birthing people and what they want, what their experience is, and advocating for birthing people in the context of maternal health and health in general. All right. And then there's the incentive side. So provider payment models. We are following closely the work at Blue Cross Blue Shield. This is where we are following their efforts, their reports, and their pay for equity initiatives, and grappling with how we could incorporate that into our approach at the GIC. We are also looking at, so for provider payment models specifically, we know that the C-section rate in 2023, for example, came in at 27.8%, and that is still higher than the CDC target of 23.9%. We are exploring how these payment models, particularly a blended reimbursement bundle or for C-section and vaginal births, may incent a reduction in this rate. And that concludes my presentation. I'd be happy to take questions from anyone on this important topic.
Oh, Jane, I see you have your hand up.
My reaction is I just want to commend the GIC and Matt and Margaret. Your presentation is, to me, it just shows such intense, not just competence, but passion for doing the work. And I just want to thank you for what I see is just very genuine, hard work. Thank you.
Thank you. I appreciate that.
I mean, we have a great staff at the GIC. I do think, Margaret, you've definitely raised our standards in data, and all that you do is very appreciated. So thank you.
Thank you.
Yeah, I mean, I'll just echo what almost all commissioners are thinking, if not all, and Toby spoke it. It would be helpful, Margaret, to give us, even in the executive director's report, some data measures towards progress, even if it's not perfection. So don't let perfection be the enemy of, good enough or even just progress. So I think that would be helpful.
thank you for that suggestion. You know, we're working the out-of-pocket report, and I'm working closely with my team to move towards providing regular dashboard data updates to the commission. A little preview of more to come. We'll give some thought to what we can present specifically with respect to health equity. You know, you heard Michael talk about the difficulty of releasing data that is not valid or complete. We're struggling with that. At the same time, we're not letting that, you heard me say, we're not letting that hold us back, because we know that our population has the same disparities that are seen in Massachusetts, that are seen nationally. There's no reason to wait on intervening. We do need to measure it, but we are pushing in what I think are all the right, you know, pressure points to get more valid and complete data while we push forward where we think we can do the most good in reducing disparities. So, Valerie, back to your comment about providing more data. We'll see what we can do. I don't want to release things that are going to be deceptive, but I'm sure we can find a kind of some sort of happy medium to feed to all of you.
I mean, even if you codify it as qualitative, directional,
yep,
steeped in, you know, some sort of progress, I think the commission would appreciate that on a more regular basis. We know you're doing some great work. Just would be helpful, you know, to hear about it. Cadence that is, you know, gives us that excitement about, you know, doing something meaningful here that needs to be done. So thank you. Yeah, I don't see any more questions. So let's keep it.
Just one more comment at the end before we move on. As Margaret noted in the prior in her deck, among the guiding principles, working in alignment with other state agencies, that we feel strongly that gives us the best opportunity to move the actual delivery system and the providers and the carrier system. The work around maternal health is also aligned with a good deal of work that's happening, driven by the Executive Office of Health and Human Services, using the wide variety of levers that they have to make policy change. So it's another area where we're looking to just closely align wherever we can. So thank you for all the comments, questions, supportive comments, all extremely helpful. Thank you, Margaret. Thank you, Michael, for all of your work on this. I hope this was helpful, and we'll continue the discussion.
All right. Yeah, thanks. Let's move forward to procurement. Woohoo. Who doesn't love a big discussion on procurement? Let's turn it over to Lauren.
All right. Thank you, Chair Sullivan. Good morning, Commissioners. I'm Lauren Makishima. I'm the Data Analytics Manager at the GIC, and today I'll be presenting the results of the data warehouse procurement. Next slide, please. All right, so before we dive into the procurement, I'd like to talk a little bit about the data warehouse itself and how we use it today. At a high level, the data warehouse is where we store claims and enrollment data for our members. That includes medical, pharmacy, and dental claims, and we currently have medical and pharmacy claims going all the way back to 2012. We currently work with Milliman as our data warehouse vendor, and they're responsible for collecting the data from our carrier partners, enhancing the data to make it more usable, and then making that enhanced data available to us in a reporting tool. Enhancing the data is a critical step, and that can include many things. For example, standardizing provider names, bringing in external data sources to assign drug claims to a therapeutic class, categorizing medical claims by the setting and type of service. These are all things that make the claims data easier to use and easier to draw insights from. Once the data is enhanced and available in the reporting tool, the analytics team can leverage the data warehouse to produce reports. The annual out-of-pocket report that we have coming up next month is a great example, but we also do analyses throughout the year to understand the GIC's spending, utilization, and cost drivers to inform strategic decision-making. We also use the data warehouse to deliver extracts to other state agencies, such as the Attorney General's office, and and to deliver enrollment and utilization data to municipalities so that they can ensure that GIC plans are offering them the greatest value possible. The data warehouse is a very complex and powerful tool that allows us to get near real-time insights into trends in the market and in our membership. And we ran a robust procurement that reflects the warehouse's important role. Next slide, please. Okay, so we started this process nearly a year ago, thinking about our needs and wants for the data warehouse. And what was most important to us in this process was ensuring that the successful bidder would be able to really partner with us and help us develop our analytic capabilities. We're a very small analytics department compared to some large state employee purchasers in other states, which means that our data and reporting projects are often limited by staff time. So for that reason, we requested that the vendor provide a dedicated analyst who could learn the GIC's data and business and act as an extension of the GIC's analytics team. Based on learnings over the last few years, we also requested performance guarantees around data quality, timeliness, and availability of the system. Finally, we strengthened the requirements around data quality and analytic groupers, which are system components that are used to enhance the data, as I mentioned on the previous slide. So in short, we wanted to procure a solution that is powerful, fast, flexible, and most importantly, staffed by a team with a strong commitment to supporting the GIC's work. So on this slide, you can see the timeline for the procurement. We had 2 scoring phases. In the initial scoring phase, which is the purple box, we scored the bidders' technical responses, cost proposals, and supplier diversity commitments. Based on the initial scores, we selected 3 finalists, and we invited those finalists to our Boston office for interviews and to perform a live demo of their solution. In the final scoring phase, which is the box in yellow, we scored the interviews and gave bidders an opportunity to improve any part of their bid through a best and final offer. Finally, the scoring team had the opportunity to award best value points. On the next slide, we'll take a look at the outcome of the procurement process and the scoring team's recommendation. Okay, so we were pleased to receive 7 complete bid submissions. The bidders are listed here in the middle of the slide. And after the initial scoring phase, we selected Merative, Milliman, who is our current vendor, and Onpoint as finalists. At the bottom of this slide, you can see the point totals for each of our 3 finalists. The scoring team is recommending that Onpoint Health Solutions be selected as the apparent successful bidder. Onpoint is an independent nonprofit company based in Portland, Maine, and they offer robust data quality capabilities and a powerful and flexible reporting and visualization platform. The scoring team was particularly impressed with the deep expertise of the proposed account team, and we felt that Onpoint would be a strong partner that can really learn the GIC's business and augment our analytic capabilities so that we can increase the usability of our data and bring new insights to the commission and the executive team. In terms of total cost, Onpoint's solution came in at just over $4.5 million over the 5-year contract term. This represents an 18% decrease from the cost of the current solution. For these reasons, the scoring team awarded 5 best value points to Onpoint Health Solutions. And I will pause here to take any questions before we proceed to the vote.
I don't see any, Margaret, but you know that means I'm going to ask a question.
Lauren.
Lauren, Margaret, both smart women, can't help but be confused sometimes. On the interview, specifically, what was the difference in interview, score between our incumbent and Onpoint? Can you give us some, granularity there?
Yeah, I think two dimensions that we were really impressed by. First was their really thorough data quality process that they run. They explained to us in great detail sort of all of the steps along the way that they take to ensure that the data coming into the system is of high quality, and of all the checks they do along the way that can help us manage data quality in a more sort of hands-off fashion. So that was one thing that really impressed us. Another aspect that really impressed us was their depth of analytic experience. They've worked with several other states to do analytic projects that were of interest to us and have produced, for example, dashboards and other sort of data artifacts that we thought would be really helpful experience to have as a sort of augmentation of our analytics team in-house.
Great.
Okay.
Go ahead, Toby.
I was just saying, Lauren, you mentioned they were nonprofit. Kind of, what's their mission then?
I don't have their mission statement on hand, but one thing that I can say is that it's very rare in this space to have a nonprofit. They were the only one that we received a bid from that was a nonprofit company.
So they go around the states. Is that their function and do this analysis?
Yeah, I believe they got their start in all-payer claims databases. I think they started in Maine, building Maine's all-payer claims database. They also have done some work with CHIA, not in a different capacity, and they've worked with several states on projects, sort of small projects, big projects, sort of a range. But I think they got their start in the all-payer claims database space.
Thank you.
Sure.
All right, great. Thanks, Toby. So one last question. Milliman is our incumbent. What kind of disruption, challenge, any, cost to us to move the incumbent? Because I'm thinking we're going to want to port all that data into whatever Onpoint has. Have we baked that in? Are we sure we're not going to get any kind of change order on pricing? What did the team look at, consider, digging into the transition, the cost, the impact, the quality of the data?
Yeah, excellent question. So there will certainly be an implementation period, and we will work closely with both vendors to ensure that all of the data that Milliman currently warehouses moves over to Onpoint, and that there is data validation. The current plan is to extend the contract for Milliman to ensure that there's a smooth transition so that we leave the current system up and running while we continue to build the new system. And we've already been in contact with both of the vendors, and they will be working with us in that process.
Hey, Anna, I see you have your hand up.
I do. Yes, thank you. I just had a question about, it was interesting that you said that she has worked with this vendor and also Maine. And is there any, I didn't really see this, and forgive me if I missed it in the materials, but like, do you sort of check references? Do you talk to those organizations about their experience? Because it looks like these two vendors were really close in their
They
score.
were.
And it's
Yes.
just the awarding of the best value that sort of tipped it. So I'm just curious what other diligence you might have done.
Yes, we did talk to other state agencies for both references for Milliman and Onpoint. And especially with Onpoint's reference, we felt that the experience was relevant and that they would be a strong partner for us. And they have a great sort of track record with other states as well.
Okay, well, disruption is real. So if you guys have dug into that and have a good plan and it doesn't look like the cost is any different, that is good to know. Hey, Bobby, I see you have your hand up.
Right. So I was just looking at, I'm sort of, I guess, perplexed because they were so close, right? And to Anna's point, it's the difference was in the best value. And I'm curious how or why Milliman received 0 for best value and Onpoint like 5. Like I couldn't quite figure out how that occurred or what, because we obviously had, a few years with Milliman and sort of, and I'm not aware that we had any sort of problems or issues. So I'm just curious how the scoring for best value, how Onpoint got to 5 and Milliman basically was 0.
Yeah.
If you could sort of explain that to me, because it's
Okay.
unclear. Can't quite figure it out.
I see Andrew has his hand up. Maybe Andrew wants to take that one first.
Sorry, I was on mute. First, just for some context, typically best value is only awarded to one bidder. It's just we have a range up to 5 points we can give for best value. So it's not a portion between. And I would note that even without the best value points, Onpoint still would have been the top bidder. But I know that Lauren has some very specific things that merited the extra points.
I can weigh in a little bit more here as well. So Milliman offers a great product and their staff works very hard, but we really felt that the difference was Onpoint's service model. They have a much more hands-on approach, and they did offer the dedicated analyst that we requested in the RFR. And we've really felt that while both companies have a good product, the service model that Onpoint would provide is really the right fit to grow our analytic capabilities going forward. So that was really where the difference emerged, that expertise in analytics and the more hands-on approach, especially with data quality, really made us feel confident that the short-term disruption would enable us to grow long-term.
Also, if I can add, I just want to remind everybody that we went through an implementation process with Milliman. We were switching from a different vendor when the Milliman contract started. And you might recall that we had a different vendor that we had picked coming out of the procurement process and then had to pivot to Milliman. So we had even less time to adjust, and we handled all those issues with no problem. And I would anticipate this being easier this time to do the crossover.
Tamara, I see you have your hand up. I think you're on mute still.
Okay, I would recommend that the commissioners look at the website for Onpoint Health. It's quite impressive. And they have worked in so many different states, specifically in healthcare claims, in data warehousing. It is quite an impressive story of that entity. So I would recommend looking at that website in terms of what they actually have done and what they do. Lauren, I think you made a great choice. And I understand data warehousing. I think you made a great choice. The fact I still don't understand the nonprofit status. Apparently, they started out working as a nonprofit because they did all the work for Maine and for the state government and in their data warehousing, and so it's really but to me, the nonprofit version for data warehousing is an oxymoron. I mean, it's really strange how they can claim to be a nonprofit, but that I would love to hear that story later, Lauren, as to how they justify the nonprofit status. But thank you for taking the risk, a calculated risk of really changing to an entity that would even would even better meet your needs. I want to congratulate you on that.
I think you're getting a little ahead of us. We do need to take a vote on that tomorrow.
Oh, okay. Oh, sorry. Okay.
You know that. You know that. You're just getting excited. And
Right.
I too want to thank and applaud the thinking of the procurement team to recommend yet another transition if the team feels that it will bring us better data, coming off of the discussion around, health equity. You need data to be able to tell a story, to make changes. So we're building that infrastructure with our data. So I applaud this. So if we don't have any more questions, we can move to a motion. And maybe Tamara, you want to make the motion to approve this. Unless there are other slides here, Lauren, I think we have motion next.
Yep, that's it for the slides.
Why don't you go to the next slide?
Okay. I so move.
Second.
So we have a motion on the table to approve the procurement. And Tamara made that and Catherine seconded it. So Andrew, can we take roll call?
We are. And what our jobs are.
Can we bring up the next slide, which has the motion on it?
Yeah, there we go.
32 years.
And someone needs to mute so we can hear Andrew taking roll call.
Help.
So
Chair Sullivan?
Andrew,
Yes.
I am voting yay, and you can proceed.
Thank you. Vice Chair Kaplan?
Aye.
Designee Sullivan?
Yes.
Designee Butler?
Yes.
Thank you. Commissioner Shabbat?
Yes.
Commissioner Choate? Oh, he had to leave at 10. He may have dropped off. Commissioner Davis?
Aye.
Commissioner Edmonds?
Aye.
Commissioner Guerin?
Yes.
Commissioner Jennings?
Yes.
Commissioner Murphy Rodriguez?
Yes.
Commissioner Silva?
Yes.
Commissioner Sinenko?
Yes.
Commissioner Sullivan?
Yes.
And Commissioner West?
Yes.
Thank you. The motion passes unanimously.
Yeah. Go forth and contract and keep us posted on output and transition. There was a lot of lively discussion and interest. Would love to hear more. I second what Tamara said. I'd love to really understand the not-for-profit status. It might be interesting to bring Onpoint into a commission meeting. Maybe once we get fully implemented, and there was a lot of discussion here for excitement around data and data warehouse. So thanks for the engagement to everyone. So at this point, I see that we might be, you want to event, yeah, at a point where we can bring up other business. I'm a broken record. I'd love to have either our May or June meeting in person. I know the staff will have to work to get us a room. I also know there's been a request to have that meeting start at 9 or 9:30 so that we can all get familiar with what it takes to get into Boston. But the weather will be good. There'll be an opportunity for us to all be together. So I look forward to hearing from staff when we'll have our in-person meeting. Otherwise, I don't have any other business, and I don't see anything here. Matt or staff, anything that you want to bring up?
Nothing further to add. Thank you.
All right. Well, so I'll give you 25 minutes back. We'll see you on May 15th. For those who are celebrating holidays, Passover has begun. We've got Easter this weekend. We've got the marathon for anyone running the marathon. Take it easy. Any viewers, congratulations in advance for what you do for your health at the marathons in your wheelhouse. And I will ask for a motion to adjourn. That was Bobby, I think. Bobby, yes.
So moved.
Second, Catherine. Head shaken, and then so all we need is all in favor, say aye.
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 And we'll see you in May. So enjoy the nice weather and the spring. And thanks, everyone.